Just yesterday, I was talking at a local meeting about the non-VKA oral anticoagulants, and it was a meeting teaching GPs about these new drugs. And the very first question I got was, what about all my patients who are taking aspirin or clopidogrel? Can I give a novel oral anticoagulant to these patients? Can they, Rack?
This is, as you said, one of the most frequently asked questions at meeting, because we have two conditions, atrial fibrillation and acute coronary syndromes, or also elective stent implantation, in which we are in a kind of therapeutic dilemma. From data that we have in the literature, about 8-10% of atrial fibrillation patients develop an acute coronary syndrome or need a stent implantation, and conversely, 15 to 20% of post-ACS or electively stented patients develop at one point atrial fibrillation and therefore are candidates to oral anticoagulation. The problem is simple in these terms. To prevent stent thrombosis after we implant a stent, we have no better tool than dual anti-platelet therapy. This is better than vitamin K antagonist, oral anticoagulants, as we used to say, because this was clearly demonstrated in all trials by Colombo, by French investigators many years ago now, showing that the combination initially of aspirin plus ticlopidin and then aspirin plus clopidogrel was better than loading patients with warfarin. And on the other hand, we have clear evidence that stroke prevention in atrial fibrillation is done best with oral anticoagulants. There was an attempt at a formal head-to-head comparison of aspirin plus clopidogrel versus warfarin. This was the Active W trial, in which we could easily demonstrate, contrary to the original hypothesis of a non-inferiority, that warfarin was better than aspirin plus clopidogrel. And so the problem is that we don't have an easy solution, and the problem of combining treatments, one for ACS or stenting, and treatment for stroke prevention leads to major bleeding. And this has been reiterated in many reports, one of which is this huge Danish registry with over 82,000 patients, in which you see something that is relatively obvious, that as soon as you add one anti-thrombotic drug over the other, you increase the risk of bleeding. And you can easily see here that warfarin plus aspirin is certainly worse than aspirin plus clopidogrel. And here also there is the finding, which I think is relatively odd, that warfarin plus clopidogrel seems to be so much worse than warfarin plus aspirin. But certainly the bottom line is that when you have the triple therapy, everything on board, aspirin plus clopidogrel plus warfarin, you have much more bleeding. And this is also in terms of major bleeding that is substantially increased. So we have to balance the risk of bleeding against the risk of not preventing stroke or not preventing stent thrombosis enough. And here we are in a difficult position. So how did the international societies behave in this? We have two important sets of recommendations, one coming from the European Society of Cardiology, one from the American Heart Association. I'd like to refer to the ESC first. Here the concept is to try to shorten as much as possible the time of overlap among all these different drugs, to keep this at the very possible minimum, because we know of this excessive risk of bleeding. So in the case of an elective stenting that is done with a bare metal stenting that is quicker to become re-endothelialized, the suggestion is to keep the time of overlap of the so-called triple therapy to 1 month. In the case of drug-eluting stents, these are different types of stent. The newer generation of stenting are allowing a quicker endothelization, are more biocompatible, and but anyway, for the limus-eluting stents, in conditions of low bleeding risk, the recommendation is to prolong to about 3 months. In the case of Taxol eluting stents, to 6 months. And you can shorten this if you are in a condition of high bleeding risk, as the guidelines say. And after this time of triple therapy overlap, you can skip one of the components, and there is uncertainty whether you could skip the clopidogrel or the aspirin component, and then after 12 months, or in case of high bleeding risk even much before, continue only with vitamin K antagonists that are a good prophylaxis also long-term for vascular disease. I will not go into the more complicated description of what the American guidelines did, but I just want to highlight that we are in an uncertain situation at the moment with the NOACs, because we have several trials that are trying to address the issue with NOACs. We have the Pioneer study that goes on with rivaroxaban, the redoA PCI, which has been recently launched with dabigatran, and a similar apixaban study is currently in the process of being launched. Just to give you an idea of what is the strategy carried on in the Pioneer AFPCI study, here we have one arm of the study that uses the conventional triple therapy with vitamin K antagonist plus aspirin plus clopidogrel, and this is this arm here. And then we have a dual antiplatelet therapy arm with a low dose of rivaroxaban, 2.5 milligram twice daily, that has been the regimen tested so far in acute coronary syndromes, but not really tested in the setting of atrial fibrillation. And then we have a more conventional rivaroxaban arm using a 15 milligram dosing, which is slightly less than was used in the vast majority of patients in the Rocket AF study, but here with the addition of only clopidogrel. And my criticism, let's say, of all these trials is that we are changing at the same time two components. So one problem is that we may not have really a clue of what is working if supposedly something will work in this condition. The other trial that is also known already in the public domain is the redoA PCI with dabigatran. So one arm receives the fully conventional triple therapy with warfarin plus dual antiplatelet therapy. One arm receives dabigatran at full doses, 150 milligram BID plus one single antiplatelet drug, that is clopidogrel, and the other receives a lower dose of dabigatran plus a single antiplatelet therapy. And here again, although I participate in this trial, I have some reservation on the interpretation of the data when they will come up, because it may be that this arm, for example, the dabigatran 150, is is very good for preventing stroke, as we demonstrated in redoA. But we don't know whether the single drug addition here will be enough to prevent stent thrombosis. We will have to see. The outcomes in this case are bleeding, death, myocardial infarction, and stroke. And also these require some thought, because it's a mixed efficacy plus safety outcome that will need some interpretation in subgroups. Thank you very much.
Well, thank you, Raf. And Frick, tell us a little bit more about how we should be handling the non-VKA oral anticoagulants together with single or dual antiplatelet.
Yeah, they're a very good point. As Raffaele pointed out, is it really safe to use only a single antiplatelet drug with, for instance, the NOACs? The NOACs will be safer in these trials you mentioned. Why wouldn't they be different from the big 4 studies we have seen? The question, though, is the single antiplatelet therapy enough to prevent ischemic events in the coronary arteries? And that is, I think, an important question. I believe, as we know from warfarin alone, that it has also some activity against coronary thrombosis. We know that from the very old, the English trial, the MRC trials, the trials we did in Norway and in Holland. So I think the NOACs have also the potential benefit of preventing coronary events. And as you pointed out, Raffaele, in the Atlas II trial, the addition of a low dose of rivaroxaban prevented ischemic events on top of dual antiplatelet therapy, but that was in a non-AFib situation. And also, maybe you know that also stent thrombosis was significantly reduced by adding, on top of dual antiplatelet therapy, an anticoagulant of the anti-10A class. So I'm pretty optimistic that we can do without dual antiplatelet therapy in this situation, and that the NOACs may also be helpful in preventing recurrent coronary events. But of course, we have to wait for the results, which take at least 1.5 years before we have those, at least from Pioneer.
So what are you doing now?
What we do now, since we did the WOES trial, that we stopped aspirin cold turkey in all patients who got a stent when they have AFib, whether they are on warfarin or whether they are on a NOAC, and they all continue on a P2Y12 blocker, mainly clopidogrel, or if the interventionist prefers prasugrel or ticagrelor in the ACS patients. So that's what we do now. But we have to see whether this is really safe to do that. But so far, it looks very good.
And Paulus, what about these different phenopyridine drugs? We're usually talking about aspirin and clopidogrel, but what about prasugrel and
well, I mean, I guess outside of the AF population, so in the non-anticoagulated patients, we probably, at least in my institution, we use a lot of ticagrelor and prasugrel in ACS patients, especially in high-risk ACS patients. But these agents have never been tested in patients who are anticoagulated, and probably rightfully so. So that our personal, well, our local tendency is to keep clopidogrel as the thienopyridine of choice, unless we have a patient with a definite stent thrombosis, which is a very rare thing, but there where you want something that, because where you have evidence that in this individual patient clopidogrel didn't work. There was actually a recent, again, a small observational report that looked at the combination of anticoagulant plus prasugrel versus the triple therapy that we are used to. And then they actually found, not that unexpectedly, that the prasugrel anticoagulant combination led to higher bleeding rates. So I think this should be reserved to really high-risk patients, if at all. I want to point out that even though we don't have the controlled trial data from the trials that Raf mentioned, we do have, I think there were about 1,000 patients who underwent stenting in the redoA trial, for example, and then they were equally randomized to the 3 arms. So there were a certain amount of patients that received triple therapy during that trial, and the bleeding rate goes up, and there is no obvious difference in the bleeding rates between those patients who were randomized to warfarin and those who were randomized to the bigger trial. So that I could think we can probably for now assume that the NOACs behave similar to vitamin K antagonists in that setting. And my personal policy is to continue the novel oral anticoagulant if a patient on a NOAC comes in with an ACS, for example, or in need of an elective stent, and then just add the antiplatelet. Whether we can drop the aspirin or not is a very interesting question, and I don't know the answer.
What do you think about that, Marco? Can we drop the aspirin?
Well, I think the WOOS trial is very compelling, although it's a very small trial. It's a little over 500 patients, so it needs to be confirmed. But the results are very promising, and we, in generally, already applying the results of the WOOS in daily practice. And again, this applies to patients on vitamin K antagonists. Whether this translates to in the same way in patients on NOACs needs to be proven. If patients come in on a NOAC in our center with an acute coronary syndrome where an intervention is urgent intervention is needed, we take them off the NOAC and put them on dual antiplatelet therapy, and after the effect of the NOAC is waned, we put them on heparin for the procedure. If it's not an emergency, we try to postpone the intervention until the effect of the NOAC is waned. And then we try to seek for ways to reduce the risk of bleeding by using a radial approach rather than femoral approach, and the usual.
Johnny, what about the non-emergency situation? Patients with chronic stable angina and atrial fibrillation with thromboembolic risk?
Yes, it's an interesting point, because I think that there is an excess of co-prescription of these drugs. And for example, you know that in the guidelines we have put that after 1 year, in a large majority of the cases, we can keep only the anticoagulant, whatever, vitamin K antagonist or new drugs. But for example, in my country, I'm sure that there is an excess, sometimes even with a dual antiplatelet therapy, because it has been started after the implantation of the stent, and the doctor don't want to stop it. So it's really very dangerous. But even to stop one antiplatelet drug is, in many cases in France, the antiplatelet is continued. We have seen recently a consensus paper published in Europace by ERA and the people from PCI and coronary artery disease, and it has been well said again that after 1 year you can stop, except some cases, but which are very, very few cases. And it's important to say that to the doctors that it's important to consider that in the large majority of cases, after 1 year, it's only one anticoagulant.
And Raf, what about these new bioabsorbable stents? Do we need triple therapy with these stents?
You need it at the beginning, because you still have, in this case, a scaffold that could be the trigger for stent thrombosis. But eventually this should be totally reabsorbed, and so would leave a non-artificial endothelium that would not need any longer any specific treatment. The only problem that have arisen from this totally bioabsorbable stent is that the scaffolding function of the stent also wanes, and so you have the complete healing, but you can have a potential collapse of the vessel that was in the original PTCA era was one of the causes for reocclusion of the vessel.
Well, thank you very much. Of course, in this situation of the combination of coronary disease and atrial fibrillation, we have to assess the risk from the coronary disease and the procedures related to it. And we also have to assess the risk from atrial fibrillation. And we have to balance the combined antithrombotic effect and anticoagulant effect of the various agents with the risk of bleeding. And at the moment, I would say we're in a bit of suspended animation because we're waiting for quite a few important trials to report. But of course, these patients still present, and therefore we have a plan, so to speak, of how to manage these patients at the moment. But the plan differs a little bit from place to place, and I think that's inevitable.